Good morning. First of all, I welcome you for the second day of third Regional Academy of Dermatology and Venereology. And the first session today will be interested. We have different subspecialty and different extension of speakers. We'll start with Professor Dirk Elston. Professor Dirk Elston, he's a professor and chairman of the Department of Dermatology and Dermatological Surgery at the Medical University of South Carolina in Charleston. And he's past president of the American Academy of Dermatology and the American Society of Dermatopathology. He served on the board of director of International Society and Dermatopathology and the American Board of Dermatology and served as editor of the Journal of American Academy of Dermatology. He is honorary professor at China Medical University, Shenyang, China, and the guest professor at the Shanghai School of Medicine, Central South University of Shanghai, China. He is honorary member of the German and the French Dermatology Society, who will talk about challenging cases from clinical case of my career and lesson I learned from them. So we hope that we learn from them. Thank you.
Good morning to the early risers. So I'll be covering three major lessons that I've learned from my patients. One is the harm that we can do as physicians. Number two is the unexpected harms that diseases can do. And number three is how we can sometimes save the day. So this poor young man has seen 20 dermatologists. His mother takes him from physician to physician, trying to cure his horrible hand eczema, and his hands keep getting redder and redder. And when you look, there really is no eczema. What there is severe, profound steroid atrophy. Everything they're experiencing is iatrogenic from the physicians who've been treating him. His palm is red with all the exposed vessels. You can see, with dermoscopy, you can see the entire vascular plexus. Stopping the corticosteroid, he burns, he itches. Very difficult to wean these people, and you need fairly effective topical anesthetics. We use a mix of topical, we call it BLT, Benadryl, lidocaine, tetracaine, topically, to ease the patient through the withdrawal from the corticosteroid. Another patient sent to me with total body refractory itch, and again, severe, profound steroid atrophy caused by the physicians treating him. Actinic purpura, but it's not actinic, it's in sun-protected areas, and again, it's a manifestation of severe steroid atrophy. All of these patients, horrible steroid atrophy. This poor woman has Hailey-Hailey disease. When I met her, she was breaking down over her entire skin surface, unable to sleep, on narcotics for the associated pain. And she had been given clobetasol that she was using in such quantity that twice a day she was putting it head to foot. Her serum cortisol was undetectable. She had profound adrenal atrophy, at risk for Addisonian crisis. She is now 2 years out, and with the use of JAK inhibitor, dupilumab, both of which can be very helpful in the setting of Hailey-Hailey, she is, and cinacalcet topically. She is off her corticosteroid. Her skin, she's down to very local areas of skin involvement. Her quality of life much improved, but 2 years out, her morning cortisol is still only at 4. And until it reaches 10, she still needs daily supplementation or she's at risk for Addisonian crisis. So again, not only severe steroid atrophy, but adrenal atrophy from topical corticosteroid caused by the dermatologist treating her. This was her face, and you can see the vascular plexus exposed. And how often have you seen Haley on the face of a patient? Her skin was so atrophic that every inch of her skin broke down with Haley. The next is unanticipated sequela of diseases that we see not infrequently. This patient has scalp crusts and erosions post-surgery, not responding to antibiotic. Everyone in the room knows that's erosive pustular dermatosis of the scalp, which is a superficial form of pyoderma gangrenosum and responds to corticosteroids and other treatments that we would use to treat PG. This is yet another patient with erosive pustular dermatosis, and another, something we recognize. This patient had a history of squamous cell carcinoma and then had erosive pustular dermatosis, and every biopsy was read by a general pathologist as squamous cell carcinoma. And so a well-meaning plastic surgeon excised and grafted her entire scalp. Of course, she continues to have erosive pustular dermatosis around the periphery and within the graft site. So we can do better than that, can't we? So we have this patient who had erosive pustular dermatosis, and we treated. And there were areas that didn't heal well. And eventually those areas are biopsied, and he has multiple areas of aggressive squamous cell carcinoma, widespread metastasis, and subsequently died from the squamous cell carcinoma arising in his erosive pustular dermatosis. Another patient, erosive pustular dermatosis, came to me because of poor response to management. She was starting to respond, but then that squamous cell carcinoma arose within 1 month of my seeing her. Moderately differentiated, deeply invasive squamous cell carcinoma. We're all familiar with Melanie ulcer, aggressive squame arising in chronic ulceration. Erosive pustular dermatosis is such a situation, and we have to be attuned for the squamous cell carcinomas that arise. When I was presenting on a panel at the AAD, we had one of my favorite dermatologists from California, Lindy Fox, was saying, yes, when we have these tough patients, we use TNFs just as we would in pyoderma gangrenosum. We reviewed these patients with aggressive squame, and Lindy said, maybe we don't use TNFs in these patients, right? So yet another patient with erosive pustular dermatosis, treated with cyclosporin, treated with topical corticosteroids, crusts not responding. After debridement, there's this area of erosion. That is his skull X-ray. It has eroded, the aggressive squamous cell carcinoma has eroded through the skull and into the brain. He saw neurosurgeons, he had it excised. He was put on adjuvant therapy with cemiplimab. They had to put in a metal mesh and graft. This is him subsequently with recurrence of erosive pustular dermatosis, breakdown. He went on to not only complete breakdown overlying the mesh, but with recurrence of the squamous cell carcinoma intracranial. not, a little bit scary. Everyone in the room is probably breaking a cold sweat at this point. We see lots of erosive pustular dermatosis. When I present these cases, people say, well, how many of these patients have you seen? One is too many. Right now, we have 6 that we have seen that went on to aggressive squamous cell carcinoma. The lesson is simply, when we treat erosive pustular dermatosis, any area that doesn't respond needs a biopsy and needs to be read by a good dermatopathologist that will not overread PEH as squame, but will not miss the diagnosis of aggressive squame, right? You're lucky you have REAM, right? So a good derm path is your best friend in this situation. Okay, now situation where we can save the day. Patient presenting with widespread eruption. You can see on the face that the color is not cherry red, it's more violaceous pink, characteristic for connective tissue disease. Additional workup, double-stranded DNA and ENA were negative, ANA was a speckled pattern. The biopsy certainly was compatible with connective tissue disease. Patient went on to fulminant dermatomyositis. Characteristic for dermatomyositis, that reticulated white avascular area with the little red vascular dots is absolutely pathognomonic. Lupus doesn't do that, only dermatomyositis does that. Additional workup looking for underlying cancer because of the severity. She had the expanded myositis panel, which we do by immunoprecipitation because that has the greatest sensitivity. She ended up in the hands of a well-meaning rheumatologist, was given IVIG and high-dose corticosteroids. Her skin never responded. She gained 180 pounds on the corticosteroid and developed bilateral pulmonary emboli while on the IVIG. Rituximab, mycophenolate, hydroxychloroquine, none of those managed her disease. This is when she came to see me. And then bariatric surgery. The bottom is the hair regrowth, and that was all with tofacitinib. JAK inhibitors are gangbusters in refractory dermatomyositis. They really are valuable additions to our armamentarium. So again, corticosteroids in this particular case, horrible morbidity associated. Methotrexate failed, and JAK saved the day. I'll leave you just with a mimic. Hyphal, fungus, hyalohyphomycosis, except that's histoplasmosis. We all learned about dimorphic fungi, right? Dimorphic fungi can be, we expect them to be yeast in tissue, but in high oxygen tension, cavitary lung lesion, intravascular, they grow as hyphal. It's not just temperature, it's oxygen tension. So a morphology that we wouldn't expect at all. I'm also a dermatopathologist. I had to throw something derm path in, unexpected, but important lesson that I learned is we learn all of our fungal identities and fungal morphology, but the fungi, especially the dimorphic ones, can fool us and change. And with that, I give you 2 minutes back, so we're back on time.